Thank you. Thank you.
Thank you all.
Thanks. Can you all hear me?
Yes, sir.
Awesome. It's good to be back. I'm sorry I couldn't be there in person. Just been quite a few months in academia, which probably many of you are aware of. And thanks for that prior talk. It was a good segue into my own talk about liquid biopsies and ctDNA and showing and sharing a little bit of what we have. I'm going to share my screen if I can.
Give me 1 second.
And Dr. Bennis with Vanderbilt.
Yep. Now you can share.
Oh, been with us for
All
a
right.
long time.
Hopefully you can all see that.
Yeah, go full screen. There we go. You got it.
Right. I'm going to use my laser pointer option. All right. Hey, everyone. It's great to be here. Again, I'm so sorry I can't miss the first return to in-person. I love Kansas City, Peggy's cooking, etc. So maybe next year.
I'll send one in the mail.
I can't wait.
Good
These are
luck.
some of my disclosure. And again, I hope I'm going to leave enough time for discussion because just based upon even the last one from Sarah and Exec, I think that this is a really great audience to do this for. And I even wanted to chime in a little bit because we've done some work on male breast cancer and Oncotype. And I remember Steve Shack, who is the originator and a good friend of mine from Genomic Health, who created Oncotype, and he was also sharing some data with me in the past about male breast cancer. So the overview, I'm going to talk a little bit about cell-free DNA technology, some of which you already heard, the goals of therapy. Again, many of you have already heard this and know about it, but I'm going to really tell you kind of in my view and opinion about where we could really use ctDNA, specifically and especially also for minimal or molecular residual disease, as you talked about, but even some other areas that we and many others have been working on, and some challenges and solutions and conclusions. So again, I don't have to belabor this with this audience. We all know that this is a huge public health problem in this country. There's 300,000 cases in the United States diagnosed, and the majority, I should say, I do this every year. I forgot to put men and women, I apologize, will be cured, but 40,000 patients die from the disease. And we know 1% of breast cancer is male breast cancer. So even though, the numbers are big, but the percentage is small, the absolute number is still pretty big, bigger than some other rare cancers. I think it's super important to remember the goals of systemic therapy. This is what I do as a medical oncologist, right? Metastatic disease, we can't cure it largely, although we're getting better at that. And there are some patients I am convinced are cured of their metastatic disease. But it's really to prolong life and treat symptoms. Adjuvant therapy, that's the bulk of what we do as a medical oncologist. And that's where we give systemic therapies after primary modality, sometimes of surgery, to really get rid of the body of micrometastatic disease. And that's what we're really talking about. And so, ironically, we cure metastatic disease only when we can't see it, for the most part. And each year, about 150,000 patients are actually candidates for these types of therapies. You might be asking yourself, if we can't see it, this is the days before we had ctDNA, liquid biopsies, molecular residual disease, how do we even know this works? And it's because of these large trials that we used to do back in the 1980s, 90s, and 2000s, where patients would get randomized prospectively in a clinical trial, and let's say after surgery they would either get chemotherapy or get placebo. And we followed these patients out for years to decades, and you can show that there's a real significant decline in the number of patients who relapse and ultimately the number of patients who survive and are cured of their breast cancer. We used to have this online calculator called Adjuvant Online, and we would put it in these terms where if you did no additional systemic therapies, you just did surgery or surgery and radiation, 63% would be alive at 10 years, that's the green here, and then about a third would die from breast cancer that came back, and then 4.3 die of other causes. The absolute benefit of chemotherapy in this example is in the yellow, so it's about 13%. But again, 13% times hundreds of thousands of lives is tens of thousands of additional lives that are cured because of this paradigm of giving chemotherapy. We know that this comes at a price. If you look very carefully, there's a little bit of an increase in the blue bar, and so we do know chemotherapy has short and long-term side effects, and that can include death. Thankfully, that's not a huge problem and still even more minimalized now that we have better supportive therapies. but it is still a consequence of chemotherapy. And probably the biggest problem that we continue to have, and why when we got in the liquid biopsy field well over a decade ago, which I'll show you some examples, this was to me one of the biggest unmet needs. That is, when I see a patient for the first time in clinic, I don't know, let's say after surgery, where that patient lies in this bar. Are they cured, whereas the overwhelming majority are, or are they going to actually relapse until we give them chemo? And even then, chemo works about half the time in this setting. And so we don't even know if it's effective or not. That's the crux of the problem. That's what we're trying to really address with this minimal residual disease, or MRD, in the liquid biopsy space. And we had this idea, like many others did, but we were one of the first groups, because this is really kind of invented at Hopkins by my former mentor, Bert Vogelstein. But what if we could use blood tests to actually detect the presence or absence of cancer in the body, no matter how small, no matter how microscopic? So the example here is if someone has a breast cancer, they're positive. After surgery, the majority will be negative, so they don't need any further therapy. But those that are positive will need additional therapies like chemotherapy. But importantly, because these are quantitative aspects, you should be able to track whether or not your chemo or whatever agent you're using is actually working. And again, probably you already had this in the prior talk, but what is cell-free DNA? What is circulating tumor DNA? All of our cells, including normal and cancer, shed DNA free-floating into the body. I call it cellular poop because we don't really think this has a function. It's probably just waste products, although some people debate that. The half-life of this is extraordinarily short, and so this is a good biomarker. It's about on the order of 1 to 2 hours. But unlike this diagram where you see the cancer cells in blue and their DNA is mutated, so they're in different colors, and the green cells are normal and they're all normal green, this is not usually what we're talking about in terms of the proportion. It's usually 1, and you heard like in 10,000, 100,000, a million cancer DNA molecules that you can detect in the blood compared to normal. So I like to use this analogy of where's Waldo. If there's younger people in the audience that I can't see, if you don't know what Waldo is, look it up on Google. There's some students that I have in my lab that have never heard of this, which makes me feel really old. But if you pretended that this picture was a drop of blood, and every single person here is a single DNA molecule, and let's say we're just looking at the people who have horizontal red and white shirts on, and that Waldo is the mutated DNA, what digital PCR is, and continues to be, is a way to rapidly isolate and amplify individual DNA molecules and analyze them quickly so that you can actually find it. And so it kind of goes like this. You isolate, you amplify, you isolate, you amplify, you isolate, you amplify, and there's Waldo. And this is actually the predecessor to what we currently call next-gen sequencing. So we got it on the ground floor with companies, especially 2 of them, Bio-Rad and Raindance, which created a technology called droplet digital PCR. And Bio-Rad's still in business. They bought out Raindance. But it's the same premise. You bleb off these little bubbles, and inside each bubble is a molecule of DNA or 0. That's where the term digital comes from. It's not electronic. It's just binary. And each one of those bubbles also has the necessary reagents to amplify the DNA and tell whether it's a mutant molecule or a wild-type molecule, or normal DNA molecule. So we did this, again, this has been published now for well over a decade. The original proof of principle study, we had 29 patients with breast cancer. We got bloods on everyone, and we got tissues on everyone. One of the patients had bilateral breast cancer, so we got 30. And then we collected bloods that we could. This was when I still at Johns Hopkins, so 17 of those patients, we got post-op bloods. Now the first thing we did is just use old-fashioned sequencing, because remember, this was a relatively new technique, and we only looked for 2 of the most common mutations we find in breast cancer, PIK3CA. And you can see about 10 patients here in the purple had this mutation in this gene, by the way, for which we now have several drugs for. When we looked at by droplet digital PCR, we actually found more, and that was expected because the sensitivity of regular sequencing for a mutant to normal ratios, you got to have at least probably about 20% mutant molecules in there. And so for the most part in the green were the additional ones we popped up, and they in fact were for the most part less than 20%, with the single exception of this one, which for some reason we could not sequence, and it might have been because the DNA was too degraded. But that's another advantage of digital PCR sequencing. You actually want small fragments and degraded fragments of DNA, so it'll actually be better pick it up. And then we tested all the plasma before surgery. Now, one of the things we don't do enough in our business right now is we collected a lot of blood because the variability of cell-free DNA is huge, orders of magnitude between patient to patient. And so we collected a lot of blood and we used a lot of DNA for these assays. So we really got down to a level where we only missed one. And that's still something that I think is, up until recently, some of the newer technologies, is hard to do. Digital PCR, I actually am convinced also is a more sensitive technique than the current next-gen sequencing, and that also was probably factored into some of our improved sensitivity. This is the post-op analysis, and again, I'm not going to belabor this, but these are all patients who were PIK3CA or had a mutation beforehand, and we look afterwards for whatever we collect. And I think you can see the ones in the red are the ones that actually had persistent ctDNA after surgery. Now, some of these patients didn't get radiation, they didn't get their chemo, et cetera. We just took what we could get. But the illustrative examples are really patient number 16. This was a triple negative metaplastic breast cancer, which is very, very aggressive type. Had a mutation, actually got screened, and got a full body CAT scan because there were some delays in her chemotherapy, which was negative, but unfortunately that patient did end up developing recurrence. So this was actually taken during her chemotherapy, and she was still, or I'm sorry, after her chemotherapy, and she was still persistently positive. On the other hand, the only other triple negative breast cancer that we had in this cohort was just these two, and that patient cleared their ctDNA and actually is cured, still has not had a recurrence. And so this is the summary, and again, I'm not going to belabor this, but suffice it to say, this is really the first example and proof that we could use ctDNA in a very kind of small way, since we're only looking at 2 mutations, to really see which patients may or may not have cleared their ctDNA, meaning they still have or don't have microscopic residual disease. So that was and I'll get into a little bit more about that later, but I think everyone can see in what was mentioned at the previous talk, this really started everyone's thinking about, could we use this to address these issues? Who's cured, who's not? Who's undertreated, who's overtreated, whose therapies are not working? And there's a whole host of other offshoots and corollaries that one could think about. Could you use this as an intermediate endpoint for clinical trials, et cetera, et cetera? All right, so one of the things that's evolved, so a very talented fellow who's in my lab and is now a world-famous investigator in her own right, Heather Parsons, published this paper and showed it at ASCO a few years ago, or San Antonio, doing a similar concept, but getting to this question that some of you were talking about, what about hormone receptor positive HER2 negative breast cancer, where these patients can sometimes recur 5, 10, 15, 20 years out or more. And so this is a type of breast cancer that, even though it has a better kind of near-term prognosis, the risk of recurrence never really goes away, based upon a big meta-analysis done by colleagues a number of years ago. And so Heather and her team at Dana-Farber asked the question, could we use ctDNA to pick up patients that are late recurrent, have late recurrences? So the answer was yes. This has, again, been published. It's summated here, where she detected in her group 8 out of 83 patients had detectable ctDNA. 6 out of those 83 developed metastatic recurrence. 1 actually developed a local recurrence. And then all 6 patients were ctDNA positive prior to their clinical diagnosis of metastatic disease. And then 2 of them had ctDNA that had not had clinical recurrence. So this is, again, a real showcase that, in fact, we could use this technology to determine if you're cured or not, or at least have more of a likelihood, I should probably say it the opposite way, more of a likelihood that you are, in fact, going to relapse. This is actually the same paper, and this just goes to show that if you are if you don't have ctDNA positivity, except for one event, one patient, for the most part, you're going to do okay. All right, and so what about neoadjuvant chemotherapy? I think many of you know that if you have HER2 positive disease or triple negative breast cancer, stage 2, stage 3, the new standard of care has been for several years, you get chemotherapy up front. And the goal there is to actually try to shrink this down to nothing. And that happens about 50 to 60% of the time. So the scenario is you get your chemotherapy, you go to surgery, and if you have 0 cancer cells that are living, both in the lymph nodes and in the breast, and a very strict definition, so even non-invasive disease has to be gone. That's called a pathologic complete response. And that is a pretty good, but not perfect, favorable marker to say that if you have passed CR, your prognosis is really, really good. If you don't achieve passed CR, there's variability in what your prognosis is, and people have come up with kind of almost pathologic staging signs to figure out what is the likelihood of recurrence or not. This has become a useful endpoint for faster drug approval, and so these two drugs were part of it: pertuzumab for HER2, pembrolizumab, immunotherapy for triple negative. And so residual disease in these two subgroups actually is used for clinical decision making, meaning if you actually have non-pass CR, you're HER2 positive, you will get a different drug for the rest of the 9 months than Herceptin, which is the standard of care, because a big study called Catherine showed you can cure more patients that way. Similarly, if you do not have pathologic complete response with triple negative breast cancer, then patients get 4 to 6 months now of capecitabine, an oral chemotherapy, because a trial called CREATE-X suggested that you will cure more patients by doing that. So this is something that's very, very important, though. I was just talking about utility. Clinical validation and utility are very different things. And for most people in the biomarker business, validation is where things stop. But one of the things you have to ask yourself, if you, for example, have a biomarker that's clinically validated just for prognosis, meaning, okay, what is the likelihood you're going to be here at 10 years, but then you have no ability to change that outcome, then it's not a clinical useful marker, meaning it has no clinical utility. And that's one of the things at least in academia, is we're really always trying to pound, does this actually have clinical utility? And so in the field of ctDNA, there's a lot of studies we have now that have validated prognostic use, meaning that, okay, what is the chance you're going to be alive or without cancer in 5 to 10 years? But not that much in predictive use or clinical utility, saying that if we act upon this, we can actually make an impact. So our approach for this big trial that we launched in 2015 was to see whether or not we could actually use this paradigm of chemotherapy up front in HER2 positive and triple negative breast cancer patients, and see whether or not if you cleared your ctDNA, did that mean potentially you don't have any disease, meaning that you have a path CR, and could you actually give those patients a no surgical option? As opposed to, if they're still positive, then they go to surgery, and they may even need more chemotherapy, as we're currently doing nowadays. So this is the study. It's run through the Translational Breast Cancer Research Consortium. Again, it's been going on since 2015. We accrued all our patients in 2018. And so everyone now has actually more than 5 years of follow-up. And this was a very simple schema. We got tissue, we got blood, and we followed these patients out. I think one of the important things for this audience to recognize, there's a lot of studies like this, but typically what they do is they'll just take blood samples that were collected on a clinical study or on a biorepository protocol, but they weren't designed statistically with predefined endpoints to say, this is actually going to prove this in a statistically designed manner. That's the difference between this study and why it's still, I think, the only, or at least one of few studies that have predefined statistical endpoints to look at this and let us parse out whether there's a difference or not. This was something that was an early look with some of our studies that we did with droplet digital PCR. Suffice it to say, one of the things is path CR is not a perfect marker. There are still some patients, this is the designated path CR, that are still going to have ctDNA positivity. And we're not exactly sure whether or not right now this is actually going to help us manage patients. Part of that is also what's been, and you've heard about, is the sensitivity of these tests. They keep getting better, and we probably are at a point right now, and we're working with a company that is one of these 1 part per million, or the ultra-sensitive range. But one of the biggest technical challenges is, how do you find this? So our initial approach with droplet digital PCR is just draw a huge amount of blood. What I've slowly learned over my career is that a lot of IRBs, for some reason, are squeamish about getting 40 mils of blood, which I still don't understand because it's not that much blood. But be that as it may, the principle here is that if you're only looking for 2 mutations, let's say, like we did for PIK3CA, those 2 mutations aren't going to be necessarily in that smaller amount of blood. On the other hand, if you drew a lot of blood, they could be. But now the thinking is kind of what you just heard from the previous talk, that if you look at more mutations, then you only need to find the one in the smaller amount of blood to say, hey, this is actually a sign of molecular relapse or minimal residual disease. So that's where the field is shifting. Rather than using more and more blood, per se, can we use more and more probes or tracers or trackers? And that way, if any one of them, it's basically taking more shots on goal, but if any one of them are positive, you have a better or more sensitive assay. All right, finally getting to metastatic disease. Right now, in 2025 and for the past few years, we can use liquid biopsies to find certain mutations that we now have drugs for. I mentioned PIK3CA mutations early on, and we have a drug called alpelisib. We now have another one called capivasertib or Truqap, and more recently we have another one, whose name I always can't pronounce, but Navo-Ilsib. It's another mutation inhibitor that you have to actually have the mutations in order to get those 3 drugs. Where we're still not really using or exploiting, I think, the ability of ctDNA to help guide therapies is the quantitative aspects. And so how would we do that? Well, first of all, Heather wrote or finished this trial. It was actually written by Julia Beaver when she was a fellow in my lab. This was the first one to really look at metastatic patients with triple-negative breast cancer and saying, hey, if we have a tissue biopsy and then we get blood, how concordant are they? Do they match up? And that may sound a little bit trivial nowadays, but back then we really didn't know. And it turns out most of the times they do match up. But one of the things that's buried in this paper is in the supplement where we actually tracked some patients where we got serial blood draws. And I point your attention to patient number 3 here. This is a patient who had this mutation in her tumor. She had brain mets, and then she underwent surgical resection and radiation therapy. And then it dramatically fell from 33.9 to 0.15. Unfortunately, she did progress systemically, and then right here, it shows that, in fact, she increased her level of ctDNA. So that was really the first demonstration in breast cancer that you could mirror the ctDNA amount with the clinical progression of the disease. And so it's become a little bit more complicated nowadays for treating breast cancer because we have so many more options, which is a good thing, but it still presents some problems of when do we use what and how do we know if it's working. And despite all the great technology, this is still how we actually do metastatic treatments. We treat with our best educated guess from clinical trials. We wait 2 to 3 months. We do another CT scan, bone scan, or PET CT, and then we repeat. If it looks like there's disease progression, we move on to the next drug. And the question that we and others really want to ask is, well, couldn't you use ctDNA as a biomarker? And one of the concepts of this is you want to actually use your drugs earlier if you can, because what happens is when you start treating, there's always going to be a clonal bottleneck, meaning that there's going to be a group of cells that are resistant to your current therapy. But then it's kind of like pruning a bush. They get stronger. There's more heterogeneity. There's more drug resistance. And so second-line therapies don't tend to last as long as first line, third line less than second line, etc. So our concept is, could we create a 1.3 line therapy, meaning that this is a randomized controlled trial where this is the standard, how we do it. This would be in a situation where we're going to take blood. We're going to take blood in both arms, but we're only going to act on this arm, where if you take blood, you get on a new therapy, and then you measure that blood again, and based upon whether it's changing up or down, we will move patients to second-line therapy with an antibody-drug conjugate, Trodelvy, earlier than they would get at the next staging scan. So that's going on. We've enrolled only about 6 patients, and we're tweaking that because there are so many new drugs here. That I already said. I'm sorry about that. So hopefully this was a little bit clarifying that liquid biopsies or ctDNA detection really can change the paradigm and rationale for how we give chemo and other therapies. This will, I am convinced, allow for an individualized approach so that we can treat patients with exactly what they need. And the real kind of big point, and some of this was said earlier, we still need the same level of evidence to really know whether these tests are helping us. We know for sure, for example, in metastatic disease, if you get an ESR1 mutation in the blood, you should probably be on a therapy that will overcome that, and we have those now. But what we don't know is for these quantitative measures, does that lead to better outcomes? That's what we're trying to do with this trial. What we still don't know is for the early stage, if you detect minimal residual disease, does acting upon that lead to a better outcome? Those are trials that everyone is doing right now, or at least preparing for, including us, but it'll take a while before that gets there. And so someone asked the question about do you do this routinely or not? I'm very careful about talking to patients about this, and I have ordered these types of tests on some of my earlier stage patients, but it's very, very challenging because I have to be honest with them, and I tell them what are the knowns, the unknowns, what are we going to do with a positive result if we get one, and the fact that all of these tests, no matter how sensitive, even 1 part per million, are not perfect, and there are going to be people where we're still going to miss. And so that's where we really need to be honest and open with patients and have complete transparency, because this is not, at this current stage, good enough to tell people whether they're cured or not. And it's really not good enough, in my view, to tell patients not to do a standard of care therapy if they have a negative result. And just the acknowledgments of my lab and all my collaborators and funding, and I think that is it. So I will stop sharing, and I am happy to take questions.
Excellent. Thank you,
No,
Doc.
thank you.
Yeah.
Dr. Ben, I just want to at least say thank you for always being willing and open to take a second look at any of our men's diagnosis and give a second opinion at any time of the day. Kind of like how my mom answers the phone, you're always there for everybody. So I want to say thank you so much for always everything that you do.
Yes.
Well, it's my absolute pleasure, and thank you all.
Anybody have any questions? No?
No questions there. You covered it, Doc.
I will tell you all that, I'm super excited about this trial. We're finally presenting the data at this summer's ASCO. And again, this has been 15 years in the making, but we have some pretty exciting data that we think the use of these liquid biopsies is going to be better than what we're currently doing with pathologic complete response. So I think it's going to be super exciting. I can't tell you any more than that because we're under embargo, but I'm pretty excited about literally a huge part of my life's work. I call it my third child is actually coming to fruition.
Yes. And we're always here for you on anything you need with our guys.
Well, I appreciate that. We're starting a male breast cancer study, and so I am probably going to tap on a lot of you to, a big chunk of it's going to be retrospective, and we just want to collect information and data on endocrine therapies that you might be on and side effects, because our hope is in the future we're going to launch a study for metastatic patients. If they don't tolerate tamoxifen or they're progressing on it, try to use an aromatase inhibitor, but not with the drug that suppresses the testes, because that makes men miserable, and see if we can use ctDNA as a safety net. And if we start to see any cancer come back up, then we would use that, but not before. And this is something, prostate cancer people are doing right now. They're using intermittent androgen deprivation therapy because men feel miserable when their androgens are shut down, basically.
Oh, excellent.
Thank you. We appreciate your time, Doc.
Thank you.
See you soon.
Take care.
You
Bye-bye.
too. Bye-bye.